Ask the Experts platform is a monthly segment that offers an opportunity for Namibian journalists to engage noted experts in one-on-one discussions on the COVID-19 pandemic. Journalists get to pose questions to experts in various sectors to ensure that they are equipped with the necessary information to better inform their readers, listeners, and viewers. COVID-19 is our common enemy. Together, we can defeat it. Proudly brought to you by the Namibia Media Trust and the DW Academy.
Welcome to yet another episode of Hashtag Ask the Experts, which is a platform made possible by the NMT. Our experts in the hot seat this morning is Dr. Armid Azadeh, who is a public health expert and founder of Dr. MacQ Online Doctor. He's joined this morning by Dr. Lul Riek, who is the regional coordinator at Africa Center for Disease Control and Prevention. Today, we're going to be talking facts about the Johnson & Johnson vaccine. And of course, not forgetting, we're also joined by Selma Moses, who is our sign language interpreter this morning. Good morning and welcome to everyone and to our doctors. Thank you so much for joining us. I'd like us to get straight into it. Dr. Riek, perhaps you can talk to us firstly about how many doses of the Johnson & Johnson vaccine did Namibia receive and when did we receive them?
Seize this opportunity to thank you for organizing this session. It's so important to ask. But before I speak specifically on the dose, let me just check back on what we are doing as an Africa CDC. As you may be aware, Africa CDC is a continental health agency set up by the African Union through the request of the head of the states, including the president of the Namibias and all the member states, that there's a need for the health agencies. Africa CDC is a mission to support all the member states in our continent to build resilient healthcare systems that will help member states to have the health security in place. We were all surprised by the outbreak of the COVID-19 that has challenged each and every continent, every country. But through the leadership of the African CDC, we are the only continent in the world that has one Africa Joint Continental Strategy. And also, even before the onset of the outbreaks, the leadership of the Africa CDC also realized it will come down to vaccines. And that's why the Africa CDC set up three strategy on how to help all the African member states in our continent to have the sufficient vaccine dose, not only just the vaccine dose, but also how to help to have a very safe, effective vaccines like what we are having today. So specifically, the African Union set up the African Acquisition Task Team that is being abbreviated as an AVET, which has signed a very historic contract with Johnson & Johnson to supply the continent with at least 400 million single-dose shot Johnson & Johnson to meet at least 31% of our continental need. Again, that strategy is set up to ensure that each member in our continent, they will vaccinate at least 60 to 70% of eligible people in Africa, which is out of 1.3 billion population of the Africa. So 2 months ago, that Abbott that contract that was signed was Johnson & Johnson. For the first time, it has delivered some of vaccines. So far, about 30 member states in the whole continent received their first initial consignment of the Johnson & Johnson. In the Southern Africa region where I work and where the Namibia is, so far, 6 member states have received their first consignment of Johnson & Johnson. So far, about 4.4 million doses has been distributed as the first consignment. Namibia has received its first consignments as well last month, and every month has been set up that each member state that signed up with African Acquisition Task Team, which is AVET, to receive at least between anywhere from 100,000, depends on how much the country requested. So they will be receiving those till when the number that's requested by the country has reached. And most importantly, he has brought us more than just the vaccine. He has brought us hope, has brought us the leadership of the African Union, the African CDC, the member states work. Because if you see, as of today, at least 1% of our vaccine needs are produced in our continent. 99% of all we need from all those vaccines, they produce outside of our continent. And the importance of this, and I need to quote the Africa CDC director in one of the biggest meetings that was called to bring all the African Union head of the state, the minister together to things and how to have sufficient manufacturing of vaccines and therapeutics and diagnostics. And he said, and allow me to quote, if we don't have ability to manufacture our own vaccines, if we don't have ability to manufacture our own therapeutics needs, if we don't have ability to manufacture our own diagnostic for any health emergency, simply, we don't have health security in place. And that's the reason that these vaccines arriving, Johnson & Johnson, into African continent have a significant historical importance, which is very unique, and that show the Africans' initiative do work, and they will work, and the Africans as a continent will not depend on the goodwill of the Western country. And this COVID-19 has been a very good lesson learned, and it's pushed us against the wall that we have to find a way to be creative, innovative, work together, because leaving one country behind is not a good option. We have to work together for the one purpose, to ensure our survival, to ensure our safety, so that we will not depend on anyone else, but into African leaders. And today, the African Leaders Initiative of the AVET vaccines is a good example, and he will motivate all of us that, yes, it's possible. If we put our mind, our heart, our resources together, we can be able to accomplish big things, good things for the safety of our people in our continent.
Thank you, Dr. Riek. I'll just a bit later, I want to, speak a bit about, Africa manufacturing its own vaccines, but we'll get into that a bit later in the conversation. Now that Namibia has received its Johnson & Johnson vaccines last month, do you know what the rollout plan for this vaccine is?
To my understanding, the rollout for the vaccine in country is already started. The vaccines is already been distributed to the vaccine centers, and they already start vaccinating. So the question is maybe when the next consignment is coming. So the ABET that has been assigned by the African Union, Africa CDC, to make the contract with Johnson & Johnson, there's a distribution plan that every month from all those member states who sign up for the Johnson & Johnson through the ABET, they will be receiving shipments. So we expect that every month there should be a consignment arriving into the country. And it has to be well coordinated to ensure that when the vaccine arrives in any country, Namibia included, it should be fit into the country plan to ensure that the distribution plan in countries has already been set up. When that vaccine is coming, it will be taken to the vaccine centers right away. It will be the training of the healthcare workers who will be do the vaccine. They already been set up, so there will be no time to waste. And each and every drop that went into every country must go into the person's hands. And this is our hope. And this is what we are doing as African CDC, not only just bringing the vaccine, we also helping the country in how to successfully roll it out as quick as possible. We are helping all the member states in the country to have more vaccine center, to do more training, and also to help the country on how to do the community engagement and the risk communication as well. We're helping the country with surveillance of the pharmacovigilance, which is mean that any adverse side effect that is arise following the vaccine is being fully investigated as quick as possible. We're helping the country also with sequencing to ensure that to have a better understanding what type of the variant, that is the variant of the concern that are circulating in each country. We are helping also with a technical support to all the in-country human resources that are involved into the rollout. Additionally, also we are helping the country to have partnerships and also in enabling environment and how to coordinate better and how to also to link with other countries that have a best practice and lesson learned so they can be able to incorporate those best practice. Over to you, Nia.
Thank you, Doctor. Dr. Azadeh, you wanted to say something, please go ahead.
Thank you. I think I like the introduction of Dr. Riek because it kind of brings in what the African CDC has been engaging with our national rollout. I serve on the national COVID task force, so I can actually give you a little bit more optics about the rollout plan and, in fact, what the procurement has been like for all the different vaccines. But you asked specifically about Johnson & Johnson, and Namibia had sort of looked at procuring about 1/3 from the African Union through the AVAT, as Dr. Riek has mentioned. 108,000 doses already arrived about 2.5 weeks ago. And that has been distributed to all the different vaccine centers around the country. And as of the latest data I saw, 17,000 vaccinations have been, of Johnson & Johnson specifically, have been rolled out. So that is something. The balance will be, as my colleague mentioned, will be periodically delivered over the coming months. There is another sort of pledge that I've seen from South Africa itself. The Republic of South Africa has pledged to donate another 50,000 vaccines to Namibia. And that paperwork is already en route to sort of procuring and getting those vaccines across border. But if we look at the plan for Africa itself, I mean, the African CDC and the WHO has set some ambitious goals for Africa. But our first goal that we had was a September 30th, where at least 10% of the population needed to be vaccinated. And that goal was missed quite badly by most countries in Africa. In fact, 70% of the countries in Africa didn't reach that 10% goal. I looked at Namibia's latest numbers, and we vaccinated almost 13%. So we are over that goal, but just barely. Whereas the wealthy countries, the West, that has been producing these vaccines mostly, they've almost 90% of those countries have hit those goals. So we're lagging behind as a continent. And really, I'd like to just mirror what the African CDC is trying to do, is to try and bring in more of the capacity, the medical services and security, as he mentions, into the continent so that we can hit these targets much better and more efficiently. Right now, as a continent, only about 4% of the continent has been fully vaccinated.
You mentioned that we received this 108,000 doses about 2 weeks ago, and then since about 17,000 people have been vaccinated. Is it then fair to say that there seems to be, bigger interest or bigger uptake since the Johnson & Johnson vaccine, has arrived?
I think it's a combination of factors. Obviously, we had our big third wave with the Delta variant in June, July, and there was a definite peak in the demand for vaccination just after that. As well, there was a backlog because if you remember, a lot of our vaccines were out of stock. So there was a backlog. And then as soon as that wave dissipated and a lot of new vaccine centers were set up, there was a huge demand and there was a backlog. So we saw an uptake in the vaccinations in general. There is interest in the new vaccines that are on, people are doing their own homework. So the Johnson & Johnson is a popular choice. And I know a few vaccine centers that I've helped set up, when I speak to them, they definitely had a lot of people coming in asking for the Johnson & Johnson specifically. And so there was a demand for that because of the data, the efficacy data, but also because of the ease of just being a single dose. But likewise, we have the Pfizer vaccine coming in, and there are a lot of people who are interested specifically in that. But from the first day when this pandemic started, really, my message has always been, the best vaccine is the one you can get your hands on. So it's not something worth delaying. It's really worth just vaccinating because all of the vaccines are showing great results in terms of minimizing the impact that this virus is doing on our health systems and on the individuals who are getting infected.
Thank you, Dr. Azadeh. Dr. Riek, as Dr. Azadeh mentioned, countrywide, we're standing at a 13% of individuals that have been vaccinated. Now, we know that the African CDC, has some goals in terms of the percentage that they'd like to see at a certain time for Namibia and other countries, obviously, but specifically looking at Namibia. We know that to reach herd immunity, we need to have our population at least at 60% vaccination. Standing with the current, status quo, 13% or 13.3%, as Dr. Azadeh said, when does it seem like we would possibly reach, herd immunity?
Well, thanks again, Nina, and let me also commend my colleagues Esther for the update that he provided in context of the Namibia response. We commended the leadership of the country of Namibia for all the effort that they put together to ensure that at least at this point in time, they managed that to vaccinate at least 13% of its citizens. That is remarkable compared to, when you take continentally and regionally, that the region there's only 2 countries that's managed to vaccinate population from 1 million and above. In the whole continent, we have nearly 31 member states in our continent as managed to vaccinate it from 1 to 5 million. So it is really incredible achievement that the Namibia managed to vaccinate it at this point in time, 13% of the eligible people in Namibia. It's happened not by accident, it's happened because of the leadership as doing whatever it takes to get the vaccines, not only just from Johnson & Johnson's, but using also its bilateral relationship to get additional vaccines. And also one of the challenges that the member states have experienced, and Namibia should not be also exceptional, how to roll out the vaccine successfully. And that's the reason when the Africa CDC review all the data, they opted for the Johnson & Johnson for so many reasons. One is a single dose vaccine that once you get it, you're fully vaccinated after 2 weeks of getting that vaccine. The second reason is also very, very stable. You can be able to restore it in normal temperature for very, very long time, or in normal refrigerator. And it will give you time to deploy it to most of the remote areas without being concerned how we're going to be able to store it. And like we said, our target is to ensure that at least 60 to 70% of 1.2 billion people in Africa, in every country, in every province, vaccinated, so we can reach the herd immunity. And this is our target, because leaving one country behind is not doing us any good. Leaving one province behind is also will not do any good. So we have experienced so many challenges. You know, the AVID mechanism that is set up by His Excellency, the President of South Africa, His Excellency Cyril Ramaphosa, at his capacity at that time when he was the chair of the African Union. This is what is working now. And he set up the AVID, and the AVID also came and set up the African Vaccination Acquisition Trust that signed the contract with Johnson & Johnson, and also the finance coming from the Afrexim Bank, which is an African mechanism, and supported by the UNECA, which is also a UN agency for Africa. And that's give us hope. And the half of the vaccines that is coming from Johnson & Johnson probably will be manufactured also in South Africa. And that will give us really ownerships, and also will give us a pride that everything is being done by our leaders, and we can be able to reach them at any time we want to, and we don't have to beg on those. But the overall the rollout of vaccine in Africa has suffered, because 26% of African need supposed to come through the COVAX facility that is being coordinated through the World Health Organization. If you could recall, back in April, during the most aggressive third wave that's happened in India, there's the AstraZeneca that is coming to Africa through the COVAX. It was manufactured in India, but the India suffers so much very aggressive third wave, and then they stops the distribution of the AstraZeneca to any continent. Africa was included. That has also caused Africa some delay. But the good news, they will start from this month contributing the AstraZeneca vaccine to COVAX facilities, and eventually will come back to Africa. Also, if you recall, it was 2 weeks ago when the head of the director of the Africa CDC was in Geneva and had a meeting with the Gavi, with the World Health Organization, with the head of the one of the issues that they discussed, how to ensure that by the end of 2021, and that's the commitment, that's the goal, that they want to make sure 30 to 40% of people who are eligible to be vaccinated in Africa get vaccines. And through 2-3 mechanisms, that's the COVAX facility will start rolling out the vaccines. Johnson & Johnson through the AVID will be also distributing the shipment of the COVID-19 of the Johnson & Johnson's, and additionally also encouraging the member states to use their bilateral agreements with other countries. And then we have seen from the United States, now also the Pfizer is coming the Johnson & Johnson also is coming. So we are very, very hopeful with the current leadership that we have. We need to have partnership. We need to work together. We need to seek any opportunity that can give us a safe and effective vaccines. We need to bring it. Like Dr. Asaf said, the first vaccine that will come, please take it, because all of those 11 vaccines that has been, those receive the emergency approval by the World Health Organization, by the African CDC regulatory force, by the regulatory system in country, all of those are safe, are effective, and we are encouraging every single person in our continent, Namibia included, please take whatever the vaccine that is available, because all of those, we as a health agency, we set up regulatory system, even with the vaccine developer, even before the preclinical trial. And the African CDC, through the consortium of African vaccine clinical trial, been part of all those vaccines. And they have access to review the data that is being released by those developers. And we can say with a confidence that our best scientists in Africa, they have an opportunity to review the safety data, the effectiveness data of those vaccines. And all of those receive the emergency authorization from the World Health Organization, from the Africa CDC Regulatory Task Force, in additionally, also the regulatory system in every country in our continent, and they are continuously monitoring any side event that is happening. They will fully investigate it, evaluate it, and provide the best guidance based on the evidence that is available. So if anything's happened, the country will not be, they will report it, and the African CDC is available as a scientist on site to review any adverse reaction following the vaccine. And that should be the confidence to our people, and should be confident to the people of media like you. It should be confidence to all of us that our regulatory systems are not sleeping, are working. And if you recall, the first side effect that was raised against AstraZeneca was not raised in Europe, was not raised in America, was raised in Africa, in South Africa. And that was triggered the pause, and that has triggered the investigation and evaluations. And after 2 weeks of the pause, the African CDC has an opportunity to review the data, and they provide the guidance that, despite the side effect that has been reported, is still the benefit of all those vaccines. The AstraZeneca, Johnson & Johnson, they are far away the risk of not getting the vaccine.
Yeah, thank you, Doctor. Dr. Azadeh, besides, the Johnson & Johnson vaccine being a one-dose vaccine, what makes this vaccine different? Talk to us about the characteristics of this J&J.
So we started with the first vaccine we had available was the Sinopharm vaccine. And that is based on a vaccine technology that we're a lot more used to, because it's been around for ages. And that is a killed vaccine. Essentially, they expose the viral particle to a chemical that makes it inactive. And that's the same as what we have with polio vaccines and other vaccines that we use in childhood. So the Sinopharm was using that sort of technology. The AstraZeneca is using what they call a viral vector, which means they take the DNA of the COVID virus, but it's not in a viral package of the COVID virus, the coronavirus. It's now put into a adenovirus, which is another type of virus. And that's like a transport mechanism to try and take this DNA into the human cell and then cause an immune reaction to stimulate your immune system to then build up the antibodies to fight the COVID virus itself. So the Johnson & Johnson is also an adenovirus. The difference between AstraZeneca and Johnson & Johnson is really where this adenovirus comes from. Whereas AstraZeneca was using a chimpanzee adenovirus, Johnson & Johnson is using a human adenovirus. But they're both non-replicating, which means these viruses don't replicate in your system. All they're doing is introducing the coronavirus DNA for expressing those spike proteins, those little, the coronavirus. Have you seen the pictures? It's got these little spike proteins that look like the spikes on a crown, and that's where the name comes from. But those spike proteins then get expressed in the human cell, and that's what elicits the immune response. So then we build up the antibodies and the T helper cells immunity to then fight against the COVID virus itself when or if you get exposed to it. So that is essentially the type of virus that Johnson & Johnson is. The main difference, apart from that, from a structural point of view, then, is how it's given. So most viruses, when they were doing the trials, they evaluated what the immune response is to a single dose, and then what the immune response will be to a second dose, and at what time period. So if you remember, when we started with AstraZeneca as well, we initially were told, those who went first, they were given a 12-week follow-up, which is 3 months. But we were then sort of right in the middle of the wave, and a lot of people hadn't been fully vaccinated and were waiting for that 12 weeks. So that was readjusted to 8 weeks, just from a point of practicality. And the fact that 8 weeks later, getting your second dose was still giving a good immune response. And so that was the recommendation that went out from our Ministry of Health. And that was to, a balancing act of getting a good enough immune response to protect enough of the population. Now, with the Johnson & Johnson, the studies showed that there was a good immune response 2 weeks after getting your shot, and even better, 4 weeks later, a single dose. So that is what the recommendations with Johnson & Johnson. So the regime, or the vaccination regime, is a single dose still with Johnson & Johnson. And I do know that there is some studies talking about waning immune responses and whether we need boosters. And that conversation is ongoing with Johnson & Johnson of whether it does need a booster and when. But at this point, it's still a single shot vaccine, and that gives a good enough immune response.
Well, I actually wanted to ask you about the conversation that's currently happening about whether there needs to be, a second booster shot for the J&J. But before we get there, let's talk about the efficacy of this one dose of J&J, which I understand is currently at 71%, prevention in terms of, getting hospitalized should you get COVID-19.
So I think it's a nice topic to talk about, because we talk a lot about efficacy and effectiveness, and the general public doesn't really know what does that mean. So I think it's good to just go back to sort of the science behind it, or just the definitions. So efficacy really is how well did the vaccine perform when they were doing the trials, the phase 3 trials. And the way they do that is they take a population and they randomly split them into two. Half of them will get the vaccine, and the other half will get what they think is a vaccine, but it's not actually the vaccine. So it's a placebo. And then they let everyone go out into life normally, and then they see what proportion of the vaccinated over the non-vaccinated actually avoided severe disease. So that efficacy number which they calculate from that. So if it's 72%, it doesn't mean that the vaccine works 72% of the time, but it means that in a population that was studied, 72% of that vaccinated group, or they had 72% less chance of infection compared to the other group. So that's what efficacy means. And you can't really compare the efficacy, the published efficacy rates of the different vaccines, because they were studied on different populations with different existing health conditions, different ethnic groups, possibly, they were roughly the same age, but they were in different parts of the world as well. So there were so many other factors that can influence them to actually compare. But the most important thing is that, does the efficacy exceed 50%? And if it does exceed 50%, then it already shows an effective vaccine. So if efficacy is 72% and then 80%, that's great, because it's decreasing the chances of an infection or a severe infection. And that's the other thing that's different. Sometimes they look at moderate or just severe infection or hospitalization. And the criteria for that may also differ in different countries. And that's why you get different, you're comparing apples and oranges sometimes. Whereas when we talk about effectiveness, it's when you actually roll out the vaccine and in a community, how does it perform in the wider population? And that's effectiveness, which takes a lot of time to gather that data to actually realize how effective these vaccines are. But being a clinician in our hospitals, in practice still here in Namibia, I can just off the top of my head say these vaccines are very effective, because I'm not seeing patients who've been vaccinated, in hospital. I'm not seeing patients getting severe COVID if they've been vaccinated. Even with one dose, a lot of them are getting a much milder COVID. Whereas those patients that were really sick, whether they were young, previously healthy, or even old with multiple comorbidities, those that got really sick were always non-vaccinated. So I haven't studied the data, and it just is a sort of just a report, a case report, maybe from an individual doctor, but I can see the effectiveness, for example, and that's the difference between effectiveness and efficacy. I hope that answers your question a little bit.
Yes, it does. And then I wanted to ask you something else, just on the points that you've just raised. It was found that the Johnson & Johnson vaccine, like we said, they said 71%, effective. But then in South Africa, for example, that efficacy percentage drops to 56%. Why is that? Is that due to the variables that you explained, in the beginning, concerning the studies that they did on the individuals to see how effective the vaccine is?
Yeah, so there's multiple reasons. Just as you mentioned, there may be a higher burden of other comorbidities that are not picked up in the South African population. We have a higher rate of HIV or people living with HIV. There may be higher rates of other malnutrition and other immune suppressing sort of conditions, and therefore, the efficacy would start to be lower. And we also know that with variants, and at the time, for example, we saw when AstraZeneca first got introduced into South Africa, there was a small study that showed that it was not very effective against the South African variant at the time. And really, that's why they sort of halted the AstraZeneca and then moved on to other vaccines. But we know that all these variants, essentially why they become a variant of concern, because variants, there are multiple variants that are occurring all around the world as the virus mutates. But in order for that variant to become a VOC, a variant of concern, it needs to show, vaccine escape, which means that despite getting vaccinated, it still has a higher rate of infecting the population. And that's maybe reasons why the efficacy numbers came down in South Africa, because there were more variants that were in circulation as compared to the initial study group.
Now, that is exactly what, the report that I read said. It was due to the variant also in South Africa that caused, that efficacy rate to go down to 56%. Now, on that note, Dr. Azadeh and Dr. Riek, you can also give your 2 cents once Dr. Azadeh has responded to this question. Should not all vaccines then be suitable, to all the variants that are out there? Is this not a cause for concern? Because this is a big question that people have. Why should I get vaccinated? And if we're now saying that, certain variants might not be able to, accommodate, a certain vaccine, this then further creates doubts and obviously, a lot more questions around why get vaccinated if you're not going to be protected at the end of the day. I
think there's a good analogy that I'll sort of explain this. You know, we drive our cars and we follow the road, the rules of the road, the stop signs, the red lights, etc. And if we follow the rules, we probably won't be involved in an accident. But we still have to wear our seatbelt, right? Now, wearing a seatbelt will prevent further injury if you are involved in an accident. Now, wearing your seatbelt doesn't stop the accident. It just prevents further injury or severe injury. Now, if you're in a country where people don't follow the rules of the road or drive more recklessly, there's even a higher chance that you will be in an accident. But you still wear your seatbelt because it prevents higher likelihood of severe injury, a head injury or being thrown out of the car. And that's why we still wear our seatbelts. So in the same way, the vaccines will prevent a severe infection or hospitalization. Now, you may be in a country that has more variants, right, for example, or more severe variants, which would increase the likelihood of an infection, but it doesn't mean you should stop wearing your seatbelt or you should stop vaccinating, because the vaccine will still prevent those severe endpoints, which is what all the studies are showing. And the latest data shows that despite the Delta variant, causing such grief in India first, and even in our wave, which was proved to be predominantly driven by a Delta variant, the vaccines are still effective, even though they were less effective. And that's why over time, the vaccines will keep improving and keep adapting to create better protection against the variants that do keep appearing.
Dr. Riek, would you like to add on to that?
Yes, thank you again, Nina. I'm experiencing some internet challenges and I drop off for quite a times. But picking up from what Dr. Azadeh just said, at this time in point, when we say as a human being, seeing is believing. Like what is happening now in most of the Western countries, those who are ending up in hospital, those who are ending up dying, are those who never had at least one dose or even 2 doses of each of the vaccine that is available. But so far as of today, we still have a confidence that all those vaccines that are pre-qualified and received the emergencies approval by the World Health Organization, Africa CDC in Africa, and also by the national regulatory system, they do work. There's a chance that you get infections, but even though once you get infected, you're going to end up with a very mild symptom. You will end up not even having a severe symptom. You may not even go into hospital. And we 100% sure you will not die from the COVID-19 as a result that you've been fully vaccinated. And that should be the motive. And that should be the conclusion, the take-home message that if you really fully vaccinated, regardless of what type of the vaccine, regardless of what type of the variant that will be still coming, you are protected. You will not die from the COVID-19. You will not end up going to hospital. I know some people, they may not, they may ignore it and they look at it simply. Why I should take a vaccine when there's a chance I still get infected? What we heard the most is dying. I think that's the end goal. We all get sick every single day. We all have, symptoms like a flu every single day, but we don't die from it. Simply, and that's why we ignore it. If you're going to end up dying from it, it's going to be a big deal. In Namibia, for example, I'm sure anyone living in Namibia, they have heard about someone that get infected with COVID-19. Perhaps they may have heard about someone who died of COVID-19. But I don't think if you ask everyone in Namibia, do you know anyone who died of vaccines? I'm sure there will be not too many people that will say, oh, I heard so-and-so died because he took vaccines. And that's the reality of what we are seeing. We're seeing there's so many misinformation that is coming up, and that's making life so difficult to the national authorities, to the to the international public health institution, including the African CDC, World Health Organization, and the country leadership. They don't know how hard those countries' leadership, the working day and night to ensure that we get vaccine into their country. As of last week, you will find so far about 5.7 billion doses of all vaccines has been deployed worldwide. And guess what? In Africa, it's only 2% of 5.7 billion doses that actually deployed in Africa. And you can wonder why there's so many feminine of the vaccine. Because vaccines save lives, because vaccine really they are effective. The wealthy country, the Western country, where the most of the vaccine are being produced, they introduce nationalism because they're people first in the state of the whole continent. And that can give you an idea if really those vaccines are really bad, why they don't want to share them with other countries. And our peoples need to know that those vaccines are really safe, are effective, and seeing is believing. You can go to any other country, people who are still dying now. In Western worlds, mostly there are people who never been vaccinated, or even if they've been vaccinated, they may have comorbidity, the other diseases that they could die from it. Because simply because you've been vaccinated, it doesn't mean you will never die. No, that's not the reason. But you will not die of COVID-19. And that's the essence of our people need to know. At this point in time, I think we need to reach out to every person in our country, in Namibia, media and others, that each and every one of us has a responsibility, have a moral responsibility to ensure that once you've been vaccinated, it's not all about yourself. When you vaccinated, you serve your loved one, you serve your community, your country, your province. Give them chance that we can reach the herd immunity where we can be able to have enough antibodies to sustain the spread of the COVID-19. And that should be the take home for people like you, our civil societies, and it's not all about the government. The government are doing the best they can, but they will not force you to take the vaccine. They will encourage you. They will provide you all the evidence that why we truly believe those vaccines are safe, why we can take them. We will support countries to do the Africa CDC on its way. We'll support Namibia. We're already supporting the Namibia. We deploy community health workers in the communities to help to ensure that the people in community understands the safety and of these vaccines and why these vaccines are okay. We are helping the Namibia also with a rapid responders, with our epidemiologists and laboratory technicians, to ensure that the Namibia government has ability to contact the surveillance, the contact tracings, and also provide the capacity building and infection prevention control in how to do treatments, case management treatments, and other areas that are truly needed. And all of those to work is just buying time. The best way for the whole world to get out of this outbreak is to ensure that in Namibia, at least 60% of the people live there are fully vaccinated. When you look into where we are now, you will see there's almost 26% drop in terms of the number of the cases. You will also see that there's at least 15 drops in terms of the number who are dying in our Southern Africa region, Namibia included. But it will not show you that COVID-19 has gone away. No, it has not gone away. It's still there. We also experience a lot of fatigue of wearing masks, washing hands, social distancing. All of those now, in the most part of the Africa, we have already 6 countries. They are already they are experiencing fourth wave. And we are also dealing with a virus that is continuously mutating, changing. And each waves, it come back very, very strong, aggressive, and get more people sick. So the best way we can do is we all work together in Namibia, in the Southern Africa region, in the continent, the world, to ensure that we have enough vaccine. And once we have the vaccine, we need to encourage the people also to get vaccinated. There's a formula that always the director of the Africa CDC is saying, vaccine plus vaccination is equal saving life. Vaccines alone, without vaccinating people, it will not do anything. So we need to appreciate the effort of the regional and continental health organization, and also the effort that is being done by the leadership and by the government of Namibia to bring these vaccines. Those vaccines, they will not save life unless people get vaccinated.
Thank you, Doctor. Doctor, I don't know if you caught part of the conversation where Dr. Azadeh and I were speaking about how the Johnson & Johnson vaccine specifically, its efficacy drops to 56%, when it was administered in South Africa. And Dr. Azadeh mentioned, the variables and reasons around that, and one of them being the variant of COVID-19 that could be in that country. That then tells us that not all vaccines are compatible with the different variants that we currently know of. And of course, then the possibility of variants that are to come in the future. We don't know how strong those variants are going to be. And then you mentioned much earlier in our conversation about, Africa as a whole beginning to produce its own vaccinations and not waiting for the Western world to sort of, help us obtain vaccines, but being able to manufacture our own. Now, there is a perception, and I use the word perception because it doesn't mean that it's accurate, that, when it comes to the African healthcare facilities or African healthcare infrastructure, it's always perceived to be, poor, for lack of a better word right now. I want you to talk to us about, the possibility and also the capacity and infrastructure that Africa really has to be able to develop its own vaccines. Because as we see, it's a game of catching up. Once there's, a variant or strain of COVID-19 that would possibly not work with any of the vaccines we currently have, it means new vaccinations would then have to be developed. Do we have the capacity as Africa to be able to do that?
Well, thank you, Nina, for bringing up this one. There's two questions. The first one, we are dealing with a very persuasive virus. It's keep mutating, like I said. We started with alpha, beta, and now with a delta, which has become more aggressive, more deadlier than alpha, than beta, but the virus that is started initially. And that's the message, that if we don't work together, if we don't do one thing together to get rid, to break the neck of this virus, we will never get our freedom back. We were living with this virus. And that should be the message, that we really, we all now know what it takes. We know if we implemented all those public health measures, we know that if we vaccinated at least 60% to 70% of our population, we can be able to contain the virus and probably eradicate it forever. Now, the COVID-19 has made Africa to realize its strengths. It's the strength in terms of the population, it's in financial strengths, but most importantly, also technical capacity of the African itself, the African scientists, the African infrastructures. And that's the hope. Like I said, as we talk today, it's only 1% of all vaccine need or all therapeutic need and all the diagnostic need are produced in Africa. If you recall, in April 2021, there was a big meeting was called by the African Union chairperson, His Excellency Musa Faki Mohammed, and also in attendance there was 5 heads of the states, and has brought together 40,000, and I have to repeat, 40,000 of the strength of the Africa, from the scientists, from the bank, from the entrepreneur, the leadership, and under the share of the African Union, His Excellency, the President of the Democratic Republic of Congo, His Excellency Felix Tshisekedi. And they adopt a communique partnership on the vaccine manufacturing in Africa. And that partnership is already start working. It may not help us in COVID-19, because during the COVID-19, the Africa CDC is like you building the boat and you riding it. You know, we try to build the system. We try to look what next if there's another COVID-19 coming up, because this COVID-19 is not the first, it's not going to be the last. There will be other outbreak that is coming. They may come up with a different name, different, how to call them different year, but we are certain that the story will repeat itself. And that's why the partnership for Africa vaccine manufacturing is already start to work. And he came up with a very, very, you know, it was a goal that by 2030, you know, in 8 years, at least 20 to 40% of all our need is the vaccine need or diagnostic need must increase from 1% we have now to 40% by 2030 to ensure that all of our vaccine needs is done in our continent. And the work is continuous. They may not help us in COVID-19, but they will definitely help us in any other outbreak that is coming. And this is our hope. And based on taking from the experience of the COVID-19, it's a lesson learned and has brought the leadership of the African together. It has brought the scientists together. We identify 5 regions. In every region will be hubs for manufacturing of those vaccines. We have in Egypt, we have in South Africa, we have in Rwanda is already started, in Nigeria, and Senegal. All those hubs, they will be starting point for the African CDC to ensure that we realize that goal by 2030.
Awesome. Thank you, Dr. Riek. Dr. Azadeh, just as we round off our discussion this morning, as we mentioned earlier, we know that the Johnson & Johnson vaccine is a one-dose vaccine, but there have been reports that have said that there could be a possibility of a second dose of the vaccine that may be necessary, or booster shot, as you mentioned it. Why would such a seemingly very effective vaccine need a booster?
So naturally what happens with all vaccines is what we call waning antibodies. So when you've stimulated your body's immune system to create an immune response in anticipation of an infection or encountering coronavirus future, your body will produce these antibodies. But over time, the antibody levels tend to drop naturally. So that's why, the worldwide recommendations are, regardless of whichever vaccine, they're looking at boosters in general. But while the world is still so far behind just getting herd immunity, the message from the WHO rightly has been, we shouldn't be boosting, the third doses, for example, in the US, for example, that the president has been sort of advocating. We shouldn't be doing that when the rest of the world still hasn't even received their first and second dose. So that conversation is ongoing, where we still need to see, when you've had a vaccine, how long does it last for? And so similarly, that question of waning immunity has included Johnson & Johnson. So AstraZeneca also has the same sort of question of, when should you get a third booster? And similarly, Johnson & Johnson, when should you get the second booster? That question is still ongoing, and the scientific community is still evaluating that in real time with rollouts in countries, for example. But while we haven't even received, only have 13% even vaccinated with our first, primary sort of schedule, I don't think it's something we need to really worry about, because we still are so far behind in terms of actually reaching our 60% immunity, which you mentioned. And I'd like to even correct that and say, with the Delta variant out there, they've even said that herd immunity needs to be at 80% vaccination to reach some sort of protection against the more virulent variants. So we need even more than 60% of the population to have some level of immunity. And that's really why the question about Johnson & Johnson having a second dose has come into the media. And that's just because all vaccines have waning immunity. Waning immunity. And the scientific evaluation of the data is still coming out to then recommend when we do need boosters for any of these vaccines.
And so what is the current longevity or period of immunity with the current vaccines that we have on the market?
So most of the studies, no one has committed to it to say you definitely need a booster at a certain time frame, because it also differs between person to person. Just like your reaction to the vaccine, everyone will have their own personal experience. But what we are seeing is that initially they said, if you catch COVID, you won't catch it again in many months. Initially they said 8 months. They proved to have waning sort of acquired immunity, or natural immunity, because it was from a real infection. Then it became 6 months, but we've seen patients who are catching COVID again within 3 or 4 months. And that time frame is becoming shorter because we're having variants come into the picture, and that is just changing the data, or changing the science. So similarly with the vaccines, initially they said, at least for a year. Now it may become 8 months, but we're still waiting to see specifically, and we have to rely on big data. So looking at the data for an entire population, and then say, on average, it will be once a year that you will need a COVID booster, just like we do with the flu vaccine that comes every year. So that, I'm not saying that is the case, that it is a year, but it is something we are still sort of waiting for the data analysis and the sort of publications to actually advise national protocols and national advisory bodies.
Awesome. Just lastly, Dr. Azadeh, who is eligible to take this Johnson & Johnson vaccine?
So the Johnson & Johnson is still being tested and approved for 18 plus. So you have to be 18 years of age to be eligible for this vaccine. And generally it's everyone, unless you have a known allergy to the components of the Johnson & Johnson vaccine. So if you've had an allergic reaction in the past, then you need to be cautious, or actually not take that J&J vaccine. If the other contraindications they say is you shouldn't have it within 2 weeks of taking any other vaccine. So some people are taking, Cervarix or HPV vaccines or yellow fever vaccines, or whatever they may need for other travel purposes. So you shouldn't take it within 2 weeks of that. Then in terms of pregnancy, they say the official recommendations are, you have to be in consultation with your healthcare worker, your doctor, for example, to decide whether the benefits outweigh the adverse events. But that has really been sort of revised recently, where pregnant women are advised to take the vaccines, because the COVID infections have been shown to be that much more severe during pregnancy. So, trying to prevent that severity by taking the vaccine is recommended. And there's been no real reported adverse events during pregnancy due to the vaccine, but we are seeing a lot of severe COVID infections in pregnant women. And then those with, the high blood pressure, diabetes, with pre-existing morbidity or chronic conditions, they are recommended to take this vaccine, because once again, should they catch COVID itself, the outcomes are that much worse.
Yeah. Thank you, Dr. Azadeh. Well, we have come to the end of our discussion this morning. Dr. Riek, I just want to give you an opportunity for your final remarks, and then you, Dr. Azadeh.
Well, thank you, Nina, for the opportunity. You know, like Dr. Azadeh has just said it, we are at the war with a virus that we are like building the boat while we are riding it. There's so much information still we don't know. You know, we are getting the vaccine and we are doing the study to ensure how long for those antibodies stay. In terms of the infecting twice, I'm the one of the people that has been infected by COVID-19 twice. And I can say with a confidence, I don't want to have it. And it goes to, even if you fully recover from it, you will have so much fatigue, so much symptom that you will go through, mental distress, and so on. So the best thing that we really need to do is prevention. Prevention is better than cure. I need to urge each and every one of us that if there's one thing that you could do to protect yourself, to protect your family, to protect your loved one, your community, please don't hesitate to do it. And when it comes to the vaccines, each and every one of us as a platform, as a voice that you could use to encourage those who are vaccine skeptical, please use it and let everybody ensure that they get the vaccine when they have that opportunity. And also for the people of the Namibia at this point, please, I need to assure you, based on the evidence, based on those scientific evidence we have now, and the role of the African CDC, that it will remain committed to support the effort of the government of Namibia to ensure that they get vaccines, and the vaccine they will get is safe, is effective. So please, when you have an opportunity, when you have a chance whenever it's your turn, take those vaccines because it saves life. Those about 3,500 people who unfortunately died in Namibia, those are not just numbers. Those are the really people. Some of them work with us, used to work with us, some they are in our community, and some they left behind a very grieving family, young children, youth, and all the impact. And that should be a motivating factor for all of us, that we don't want to see any child to be orphans. We don't want to see any young man that to be orphaned simply because of COVID-19. So each and every one of us can go out and take the vaccine. Once you take the vaccine, you will save your life, you will save the life of your loved one, your community, your people, your co-workers, and we can get our life back, the life before the COVID-19, the freedom that we truly enjoy. So in short, vaccine plus vaccination means saving life. Go out and take the vaccine when you have the opportunity. And thanks, and God bless you.
Thank you so much, Dr. Riek. Dr. Azadeh, your final remarks?
I think Dr. Riek has really emphasized the importance of vaccination. And I think that is the topic of today's briefing, really was about the Johnson & Johnson. I'd just like to reiterate that all of the vaccines are effective and safe, and they have been proven to be the best tool we have in our fight against COVID, both to save our lives, save our livelihoods, and it's really the only viable solution that we have at our disposal right now to effectively move on productively with our lives as a nation. So I would just encourage everyone to, the Ministry of Health is opening up vaccine centers all over the place, trying to make the access to the vaccines there. And we just encourage everyone to, go and get vaccinated.
Thank you so much, Dr. Riek. Dr. Azadeh, thank you for joining us. We appreciate it so much, taking time out of your busy schedules. Thank you for being on today's program.
The Ask the Experts platform is a monthly segment that offers an opportunity for Namibian journalists to engage noted experts in one-on-one discussions on the COVID-19 pandemic. Journalists get to pose questions to experts in various sectors to ensure that they are equipped with the necessary information to better inform their readers, listeners, and viewers. COVID-19 is our common enemy. Together, we can defeat it. Proudly brought to you by the Namibia Media Trust and the DW Academy.